thank you, and thank you for having me today. So this study we titled Perioperative Modified FOLFIRINOX for Resectable Pancreatic Cancer. So that name tells you a lot about the study's design. But at the time, FOLFIRINOX was only used in the metastatic setting. It was became standard of care as initial therapy a standard of care, I should say, as initial therapy in about 2010. And this study began in 2014. So at the time this study launched, in 2014, obviously a decade ago, the time this study launched, the adjuvant therapy, so the therapy we did after pancreas cancer was resected, was a single agent gemcitabine, which is not very effective. And the idea was to translate something used in the metastatic setting, this active chemotherapy regimen, FOLFIRINOX, to the localized setting, to where the pancreas cancer had not metastasized. Unfortunately, pancreas cancer is a cancer that metastasizes very early, and only about 15 to 20% of patients present like this with resectable disease. And the idea was to move this therapy to that setting, that again was only a standard in the metastatic setting, and see if we could improve how patients do. So we were comparing at the time, did this regimen look better compared to single agent adjuvant gemcitabine? But not only were we using this regimen in a different setting, the resectable setting, we were using it in a neoadjuvant fashion, or really a perioperative fashion of giving some chemotherapy before and some chemotherapy after surgery. So we were looking at the time, a novel chemotherapy in resectable disease, but also in the neoadjuvant setting, which has certain advantages. The design of the study was patients that were diagnosed with resectable pancreas cancer were potentially offered enrollment, and we were very careful with surgical oncology review at tumor board, and obviously a review by the medical oncologist to make sure there was agreement that the patient met the criteria for resectable disease. And those patients that were enrolled were treated with 6 cycles of neoadjuvant FOLFIRINOX, modified FOLFIRINOX, the Yale modified regimen, which is very similar to other modified regimens, and followed by surgical resection, and then followed by adjuvant 6 cycles of FOLFIRINOX. So a total of 12 cycles, FOLFIRINOX with the surgery in the middle, and that was the design. Circulating tumor DNA was, research labs were drawn at various time points for the study, and ultimately some of them were used for circulating tumor DNA. So these labs were drawn pre any treatment. They were drawn after those 6 cycles of neoadjuvant FOLFIRINOX. They were drawn after, so right before surgery, and then they were drawn right after surgery, and then they were drawn at the end of all treatment, as well as during the surveillance period. So patients that finished all of that treatment and had no evidence of disease and were in surveillance. Now, we were not analyzing the ctDNA in real time, so the treating physicians didn't have that information. Actually, like I said, a decade ago, things were very different. We have a much more sophisticated tumor-informed circulating tumor DNA analysis, which is what we ultimately used. We used the Signatera test by Natera through a collaboration with them to analyze the tumor tissue for and makes tumors patient-specific ctDNA tests, and that's what we do. We were able to detect circulating tumor DNA in the majority of patients. I think somewhere around 73-74% of patients had circulating tumor DNA at baseline. And the baseline levels didn't seem to be predictive of outcomes. Now, the post-op time point was. So I think, one way to interpret that is despite the majority of patients having detectable circulating tumor DNA at baseline, there was still a benefit. There still seems to be activity with FOLFIRINOX using it in this neoadjuvant fashion. I think one nihilistic viewpoint would be, well, if we can detect circulating tumor DNA, it's going to be pretty challenging to treat patients effectively and potentially cure them with systemic therapy. Thankfully, again, this is the whole point of this was to use a very active systemic therapy regimen. So most of those patients actually cleared their circulating tumor DNA after those 6 cycles of FOLFIRINOX. And it was the patients that didn't clear their circulating tumor DNA with the combination of getting their tumor out and having all that FOLFIRINOX that clearly had inferior outcomes. And we saw highly significant differences in outcomes for patients, whether or not they had circulating tumor DNA positivity versus negativity at that post-op time point. But that post-op time point seemed to really be the most informative time point. I think another thing we were interested in is for the patients that start positive and clear versus the patients that don't clear, how do the outcomes compare there? But it then ended up, again, really being that post-operative time point that was predictive. But clearly, despite having circulating tumor DNA at baseline, patients could still have excellent outcomes as long as they didn't end up being post-op positive. This kind of goes without saying, but if you're able to complete all of the therapy, patients typically did better. This is a very challenging type of clinical trial to run because we're not talking about just giving chemotherapy. We're not talking about just doing surgery. We're talking about doing both and then monitoring how patients do. And unfortunately, the pancreas cancer is a very challenging cancer to treat. There's a lot of complications that can come about along the way. And we've seen that with other published trials that have used neoadjuvant or perioperative therapies. There's a lot of things that derail treatment for patients, and therefore, in a trial, also derail their treatment on the trial. And so it makes the data actually pretty challenging to really assess. Then when you're comparing to patients, when you're comparing a neoadjuvant or perioperative trial like this to historical control of an adjuvant study, there's so many confounders in that, because if you're comparing to a study with adjuvant gemcitabine, all those patients have already had a successful operation and are being enrolled, whereas we're enrolling patients earlier on in the process, and patients with bad biology, where their tumors are really aggressive, are enrolled in a trial like ours, whereas they're not enrolled in some of these other historical trials. But we found for the patients that get through all of the therapy, we didn't even reach their median overall survival. And for the patients that so they did quite well. We also found some other interesting biomarkers. We looked at keratin 17, which a colleague of mine, Dr. Escobar Hoyos here at Yale, her lab has really pioneered on that analysis. We had some findings that suggested that may be prognostic and potentially even predictive of benefit from FOLFIRINOX. Now, these are retrospective, exploratory rather, analyses, and not all the patients had sufficient tissue to get that testing done. So these didn't achieve statistical significance, but there seems to be something there when we look at the Kaplan-Meier curves, and we'll certainly look at that in future analyses. So we found, and just kind of summarize that, we found that overall in the treatment population and an intention to treat population, we found a PFS, a 12-month PFS of 67%, which was our primary endpoint, and exceeded the historical control with adjuvant gemcitabine, despite all those confounders that I mentioned of comparing a perioperative to a postoperative study. And also, we found excellent 2-year overall survival of 59%. Now, I say excellent compared to the historical control. We need to do far better with these numbers. But again, a median overall survival not even reached for patients that get through all of the therapy, which is very informative for giving information to patients about what's my recurrence risk later on. And then we found these interesting biomarker analyses, but that post-op ctDNA can be predictive, and keratin 17 likely has future roles to play. I think the biggest thing, and one thing we write a few times in the manuscript, is we need randomized data. So I mentioned the difficulties of comparing a perioperative or neoadjuvant study to an adjuvant study in terms of how informative the survival and the efficacy outcomes are. So what we need is a randomized trial where patients are randomized up front to surgery and adjuvant therapy versus the perioperative approach, because also one thing we didn't talk about yet is the standard of care has changed. It's not adjuvant gemcitabine to compare it to anymore. Now it's adjuvant FOLFIRINOX, and our trial started even before that. So just telling you how early in the process of these drugs we got started in this trial. But so we need a randomized trial, which is what's ongoing. So this is the Alliance trial that's comparing surgery and adjuvant FOLFIRINOX, which is arguably the main standard of care used nationally or globally, and compared to basically an approach very similar to ours, where you get 8 cycles, though, instead of 6 cycles of perioperative FOLFIRINOX surgery and then the adjuvant treatment. So that early randomization eliminates a lot of the confounders, and we'll really see, is doing this earlier beneficial? You know, are we treating micrometastases earlier and therefore enhancing our cure rates? Are we also preventing people from a futile operation that have really aggressive disease? I think that's actually important too. Are we downstaging the tumors locally to allow for a higher rate of R0 resection, which we had an exceptionally high rate of R0 resections, complete tumor margin negative resections in this trial. And so all these things are, show that suggest that there's, significant potential there that neoadjuvant therapy can really be better than just doing everything in the adjuvant setting. I mean, this is a very challenging disease to treat. Patients get very sick very quickly. This is a very biliary obstructions. These are very narrow areas of the body where small perturbations in what the cancer is doing can have really outsized impact on infection risk and performance status and hepatic liver decompensation. And so this is a challenging type of trial to run, but I think our results are very encouraging that there is a potential there that this could be a more effective strategy. And we await the Alliance trial. We have that trial open here. We're eager to continue to contribute patients to that and see those results.